Welcome and thank you for joining us for tonight's session. This webinar is the second of 4 webinars discussing all things fertility. My name is Dana Harris from the Hunter New England Central Coast PHN education team, and I'll be facilitating today's session. I'd like to start by acknowledging the traditional custodians of the land that we are meeting on today and pay my respects to elders past, present, and emerging. Before I introduce our speaker for today, I have a few things that I'd like to let you know. We ask that all questions be placed in the question box. We will answer these questions throughout tonight's presentation. We will be recording tonight's webinar and it will be uploaded to the PHN training library in the coming days. And after tonight's session, there will be an evaluation survey that is required to be filled out for CPD points. I'll now introduce you to our presenter tonight, Dr. Erin Fuller. Thank you for being with us tonight, Dr. Fuller, and I'll hand it over to you.
Thanks so much, Dana, for having me. So I am just going to go through this presentation tonight. Very happy to answer questions as we go. So I think that's probably the best thing to do. So I'll just keep looking out for the questions and answer them as I see them. So again, just Dana's already done this, but would just like to acknowledge the lands on which we meet, the Awabakor and Warramai particularly is where I am, and recognise the elders past, present and emerging. So just a little bit about me. I am a fertility specialist in Newcastle. I've been in private practice for almost 11 years now, and have been slowly over my time focusing more and more on fertility, and to the point where this year I have actually dropped all general gynae and am just focusing on fertility. I also do have a public position at the John Hunter Hospital where I also run a public fertility clinic and do some operating up there, as well as training registrars and medical students. The fertility service that I work with is obviously Genea. So Genea Newcastle is where we're located, and my rooms are the Newcastle Fertility Specialists. So we're going to focus on male infertility tonight predominantly. The main aims that I've sort of put there is some interpretation of semen analysis from the perspective of you've ordered it as a GP and you're wanting to give the patient some information on what that shows. It obviously, you don't need to understand it in potentially as much complexity as I do, but just being able to essentially give the patient a little bit of an idea about whether it's normal or abnormal. I thought understanding some factors that can affect male fertility and common conditions causing male infertility. How can we improve male fertility, and then some common treatments that we use on a day-to-day basis for this. So male infertility is really common. It accounts for probably about 30% of all cases of infertility in couples, and taking a history from the man is just as important as taking a history from the woman. So I really try and stress this when I'm teaching my registrars, that even if the male isn't present, and ideally that they are for fertility consultations, but even if the male isn't present, you can get at least a fair bit of information from the female. But if the male is there, then obviously directing those questions straight to him. So things that I think are really important. Previous fertility history, and that includes any previous pregnancy and the outcomes of any of those pregnancies with the current partner, but also with any previous partners. So if that man has already had 4 children in a previous relationship, that is fairly good proof that his fertility is potentially okay. Testicular disease in the past, because that can point you towards that there may be male factor present in the couple. So cryptorchidism is a big one. There is a substantial association with a history of cryptorchidism and poor semen analysis results, and therefore male infertility. It doesn't mean that every man who has a history of cryptorchidism will be infertile or have difficulty with fertility, but it's a definite association. And it always, in my mind, ups my thoughts as to, is this going to be male factor? A history of torsion as well can compromise the testis function in the future. Trauma, infections, and surgery in the area can all have an impact on spermatogenesis. Social things are important to ask about. So smoking, and the big one these days, vaping. Vaping seems to be just as bad for spermatogenesis as smoking. So asking about those things. Alcohol and how much, other recreational drugs. And I've included testosterone and steroids there because that is rife, particularly amongst the patient population that I see. There is a huge amount of black market steroid and testosterone use that can have substantial effects on spermatogenesis, and often renders that couple with no ability why they're still taking it to fall pregnant on their own. Occupation is important, things like prolonged exposure to heat, pesticides, those kind of things. So what do they do for work is an important question. They're just general medical history. So any major medical problem can have an impact on spermatogenesis, particularly endocrine disorders or autoimmune diseases, or just any other major medical problems that are prominent and not necessarily under control. A family history. So did the man's parents have difficulty conceiving? That might lead you towards wondering about whether there's any kind of inherited component to it, any other major medical problems that affect family members, and their actual medications. So there's a bunch of medications that can have an impact on spermatogenesis, so eliciting that history. The next point is sexual history, which is really, does the man struggle with erection, penetration, or ejaculation, or all three? Quite often I'll be in a consultation and we'll be sort of going through all of the things, and there won't be any mention of this. And then right at the end of the consultation, just before everyone's about to stand up and leave the room, they kind of go, oh, by the way, we're having substantial trouble in that situation. And it's often that the guy feels somewhat uncomfortable talking about it. So really just eliciting that is present and whether anything has actually been done about it so far. And if not, then exploring what might be contributing to that. So I've had some patients who have got some major medical problems that are interfering with those things. Sometimes it's that they weren't having any problems whatsoever until they started trying for pregnancy, and then it was almost like the psychological stress of trying each month and therefore having to perform at a particular time of the month every month becomes so much that then there is problems with sexual function. So investigations, the good thing about male factor fertility is that it's quite easy to investigate. Female investigations are often more complicated, there's more steps to them, whereas really get a semen analysis, is it normal or abnormal? And if it's normal, you're ruling out male factor fertility. If it's abnormal, then there's a reasonably, succinct set of investigations that need to be done. So I actually find it quite a relatively easy thing to investigate. So the other good thing about male factor fertility is that there's highly effective treatments most of the time. I'm not going to say all the time, but most of the time we can substantially help couples where there is male factor fertility, and there is potential room for improvement. So as opposed to women who are born with their eggs and that is their eggs for life, we don't make any more. And we can't really so much change the quality of those eggs. They just kind of are what they are. Men make sperm all the time. It's continuously being made and continuously being potentially either detrimentally affected by lifestyle or other medical factors, or potentially benefited by lifestyle or other medical factors. So there is potentially something that we can do to improve things. So semen analysis is obviously a big key in what we need to do for a man. Now, this can be done through most general pathology labs, but I do always stress to the patients that they need to make sure that they are dropping it off to a centre that actually can accept the semen analysis. The number of times that I've seen someone who just dropped it off to a general path place, it sat there for 4 hours before a courier picked it up, and then it's a completely useless sample. So if they're not going to an actual fertility unit such as Janaea, a reasonable proportion of my patients live much more rurally than Newcastle. They need to find out where close to them can actually accept a semen specimen to be examined, because it really has to be examined within a short time frame. The other point to a semen analysis is that it needs to have some instructions given to the man when he actually does it. So the instructions that I always give are, if they're coming through Janaea, they need to make an appointment for the test. If they're going to a general pathology place, they need to find out where that they need to make an appointment and where they need to drop it off to. There needs to be a period of abstinence prior to producing the sample. So we usually recommend about 2 days, but ideally no longer than 7 days. The sperm are quite temperature sensitive, so if the man produces a sample at home, we usually suggest that they put the pot in their pocket while they're driving it into the clinic. It would just keep it a bit closer to body temperature, and therefore have less effect on the parameters that we're investigating. And ideally, the sample should be examined by the scientist within about an hour of producing. Now, our scientists will kind of push that out to max an hour and a half if need be, but within an hour is the ideal time frame. We also do have a room at Janaea Newcastle if the man either lives too far away or he would prefer that, where he can actually produce his sample there. So that's a definite option through our unit. It's a relatively simple test. It's non-invasive. It's reasonably inexpensive. And as the slide suggests, a normal result excludes male factor in up to 90% of cases. So a significant proportion of patients will order a semen analysis, will see the results, and will say, that looks completely normal. Well, we don't have to worry about the sperm at this stage. If it is abnormal and you need to repeat the semen analysis to get more information, and I would always suggest repeating the semen analysis to get more information, there needs to be a time frame in between the semen analysis. I would usually suggest about 6 to 8 weeks, and that's just so that you're not having the same. So, for example, COVID infections in men have been causing substantial short-term reduction in all semen analysis parameters. So if they're producing a sample after a COVID infection, it can look quite abnormal. There needs to be time for recovery of spermatogenesis and for us to see a sample that doesn't have the same potential impacts on it, so that we can see, is this something that's ongoing and therefore a true problem, or is this something transient due to an infection or something else that was going on in the man at that point in time? So generally, I would recommend about 6 to 8 weeks in between. So what are the parameters that we like to look at on the semen analysis? Volume is important. So either it's mainly too small a volume is a potential issue. The concentration or how many sperm is a very important parameter. This particular picture says mobility, but we usually call it motility. So how many sperm are moving? And that's a percentage of the total. And there's two parts to that. There's what we call total motility, which is how many sperm all up are moving. And then there's the more important parameter, which is something called progressive motility, which is how many sperm are actually moving in a way that's going to be helpful in them getting up through the female reproductive tract and meeting the egg. So progressive motility doesn't mean that they're just twitching or going around in a circle. It more means that they're actually moving forward and therefore potentially going to reach the egg for fertilization. Morphology, or how many look normal down the microscope, is also a percentage. Morphology is essentially based on human, so concentration and motility are absolute numbers. They are how many sperm are there in that sample and what percentage of those are moving and moving well. Morphology is based on criteria that we as humans have decided that is a normal shaped sperm. Not many sperm that are made fit that criteria of normal shape. So it's quite common to have a low percentage of sperm that are morphologically normal. A lot of men that I see are really concerned that their morphology is only 1% above the normal range, until I sort of explain to them that in fact that's actually quite common and shouldn't really cause too much of a concern. Vitality is the number that are actually sort of alive in the sample. So it's another one that we also look at. But I must say, of those 5 parameters that are up on the screen, the middle 3 are the ones that my eye goes to straight away. And I think if you take anything from tonight, knowing what's a normal concentration, normal motility, and normal morphology, I think is probably your absolute money ticket in terms of what to walk away with. So in terms of normal parameters, and these are based on the WHO criteria, in terms of concentration or count, a normal range is 15 or more million sperm per mil of semen. Okay, so there's lots of sperm. Over 15 is normal. 10 to 15 is definitely reduced, but the chances of spontaneous pregnancy are still reasonable. Under 10 million per mil, you're sort of now looking into that's probably actually having a major impact on their chances of pregnancy. Total motility is 40% or more moving, but as I said, the more important one is progressive motility, and we want to see over 32%. Again, if there is not good progressive motility, or if there's poor motility all up, the chances of enough sperm getting up to the egg for fertilization decreases dramatically. Morphology, 4% or more is the normal range. So really, of those 3 things on the screen, the ones with the blue arrows next to it, in my view, are the most important things to look for. So if you can remember, concentration over 15 million per mil, progressive motility over 32%, and morphology over 4%. But all semen analysis have the normal reference ranges on it, so you can just refer back to that as well. Just some other things that we can sometimes note: if there's lots of white blood cells or other sort of cellular material, then sometimes it can indicate an infection. So I'll often then either send the sperm away for culture, the semen sample away for culture, and particularly make sure that an STI check has been done. And volume, it's just important to check with the guy. Does he think that part of the sample was missed? So does he feel like actually about half the sample didn't make it into the jar, and that's had a substantial impact on the volume and therefore also potentially the other parameters as well? What does it mean? So when we're looking at a semen analysis result, and I have a couple in front of me, how much that might be impacting their chance of pregnancy is variable. If the concentration is 14 million per mil, and all of the other parameters are completely normal, that's so close to normal that it's probably not having a major impact on their chance of pregnancy. If I'm looking at a concentration of, 1 million per mil, the chances of this couple falling pregnant on their own, if this is a true reflection of what this man makes on a day-to-day basis, is very low. The number of factors that are abnormal will substantially reduce how the chances of pregnancy. So I thought this graph, and I thankfully got some help from Dr. Derek Locke, one of my Janaea colleagues in Sydney, from some of his slides of a presentation that he did. And I got this table from him, and it's basically got the number of factors that are abnormal in the semen analysis, the monthly chance of falling pregnant for that couple trying for spontaneous pregnancy, the mean years to pregnancy, and what percentage you're going to be pregnant within a 2-year time frame. And I thought that this is a very, very succinct way of showing how much more than one factor that's abnormal on a semen analysis can have an impact on the chance of pregnancy. So if all parameters are normal, and you are an average age person trying for pregnancy in Australia, so say the woman is, say 32, something like that, their mean time to pregnancy, their monthly chance is going to be about 20%. Mean years to pregnancy is about 4 months. And 93.6% of them are going to be pregnant in 2 years, so a substantial proportion. If there's one factor abnormal, your monthly chance will drop down to 5%, with a 2-year time frame to achieving a mean to achieving a pregnancy, and only 63% will be pregnant by 2 years. 2 factors, we're down to 1% monthly chance, 7 years to fall pregnant, and only 20% pregnant in 2 years. And if you've got 3 factors, your mean years to pregnancy is 40 years, with only almost 5% pregnant within 2 years, which is really quite significant. And I think showing these types of numbers to patients helps them understand what kind of an impact that the semen analysis results are having on their chance of pregnancy. So what are some other investigations? Really, these things are only thought of if you've got an abnormal semen analysis. So if you've got a plumb normal semen analysis, your investigation for the man at that stage is probably going to stop. Other things that we may do, so looking for anti-sperm antibodies, this is done on a semen analysis. So when females are embryologically being made and their immune system is forming, the eggs are actually already present. So the female immune system views the eggs as part of self and doesn't attack them. So the eggs in the ovaries don't have to be immunologically sequestered from the rest of the immune system in a woman. Men don't make sperm until they go through adolescence. So essentially, there is no recognition of sperm as self by the male immune system when it is forming. And so the testes and the sperm have to be completely immunologically separated from the man's immune system, or it will attack it because it is not seen as self. So the testes have the blood testes barrier, which is essentially an immune barrier. Anything that breaches that barrier will have the potential of leading to anti-sperm antibody development. Now, once they develop, you kind of can't get rid of them. It just is what it is. And the anti-sperm antibodies sit and attach to the sperm and make them function much more poorly. Lots of different factors can lead to anti-sperm antibodies. So a vasectomy can lead to anti-sperm antibodies if you then end up with a vasectomy reversal. Any kind of testicular operation or operation in the area that includes the ejaculatory ducts, history of just trauma, so a major knock to the testes can just disrupt that barrier. So there's lots of potential causes of that. It needs to be ordered as an extra on the semen analysis. It's not done as a standard, and an extra test is run on the semen sample when that's ordered, to see whether there are positive significant antibodies. A hormone profile is definitely important if there are abnormalities on the semen analysis. The main things that we want to look at is obviously testosterone levels, LH and FSH, and it's very important to make sure that they are first thing in the morning. The guy doesn't have to fast, but male hormones do have quite a substantial diurnal variation, so I just make sure that the man knows to go first thing in the morning for those ones. Other bloods that I would order as a routine on anyone with an abnormal semen analysis, and this doesn't need to be after 2. If I've got 1 abnormal semen analysis, I'll start to order these earlier investigations just to sort of see whether we can come up with a reason why that might be happening while we're waiting for the 6 to 8 week gap before we do the second one. So full blood count, USCs and LFTs, a HbA1c, TSH and prolactin are important screening things, and they're really to screen for other disorders that might be having a major impact on that man's health and therefore on spermatogenesis. So endocrine disorders like thyroid function, prolactinomas, poorly controlled diabetes that's either poorly or undiagnosed. Really substantially abnormal USEs and LFTs might point to another medical condition, and that patient, if I order those, I might be sending back to one of you to further investigate that. A karyotype, I think, is quite important. Once you've seen an abnormal semen analysis, you want to make sure that there's nothing underlying from a genetic perspective, particularly things like Klinefelters or a translocation, which can sometimes be associated with poorer semen analysis results. Now, the next 2 things are specific for when there is no sperm in the ejaculate or complete azoospermia. So 2 things that can lead to azoospermia is either CF carriage with congenital absence of the vas deferens or Y chromosome microdeletion. So I would always order both of those as a standard if there was an azoospermic result. You can do a testicular ultrasound. It's not necessarily always needed, but that is another tool in our repertoire, particularly if there's a history of some kind of damage or other concern, like if they think that there's a big swelling or they can feel some kind of lump or mass. Sperm DNA damage tests can also be ordered. Again, these are specialized tests that have to be requested specifically. Unfortunately, in Newcastle, we have no ability to run a tunnel assay or a SCAT test, so our patients have to travel to Sydney for those. But sometimes that's necessary if we're worried that there's a high level of sperm DNA damage within the sperm and that's affecting the way that they're functioning. So I thought I'd just put a little bit about anti-sperm antibodies. As I said before, it needs to be specifically ordered. Why would I order it? The biggest reason for ordering the anti-sperm antibodies would be substantial reduction in motility, because the anti-sperm antibodies sit on the sperm and they bind to it and they affect the movement of the sperm. So if there is poor motility, I'll always want to rule out that isn't from anti-sperm antibodies. Any history of surgery or vasectomy reversal, you want to rule out that that's not the case. And all of our patients who end up needing IVF all get it done, because even if all of the other even if all the semen analysis parameters are completely normal, if there are positive significant anti-sperm antibodies, then that substantially reduces the chances of that sperm having the ability to fertilize the egg, and our scientists will always preferentially use ICSI, which we'll get to in a moment, but basically injecting the sperm into the egg, because in their view there's too high a chance of poor or failed fertilization of the eggs. So all of our patients who are having IVF, if they haven't had that test done by the time that they get to their day of the eggs being collected, then the scientists will run that on the sperm sample on the day. And if there are significant positive anti-sperm antibodies, then they'll swap to ICSI for fertilization. I am going to credit some of my scientists for getting me these two pictures. So these are real pictures of positive significant anti-sperm antibodies. They actually had videos, but they were going to be too hard to play on this, so they've just screenshotted some ones. So on the picture on the right, you can see the biggest sperm in the middle of the screen, and there is a clump of something stuck on the end of the tail. So they are positive, significant tail-bound anti-sperm antibodies. And then on the picture on the left, some of those sperm that you can see there have what we call head positive significant antibodies. So there's a substantial amount of antibodies bound to the head. They can be anywhere all along the sperm, and when we get that ASA or the anti-sperm antibody result, it actually gives a percentage of how much is bound to the head, how much is bound to the tail, and it needs to be over about 50% for it to be positive and significant in terms of the effect on the sperm. So do I examine all men? No, I don't. If they've got a normal semen analysis, then I don't think that there's anything much to gain by an examination. However, if there are abnormal semen analysis parameters, particularly azoospermia, then an examination is really important. BMI is obviously important. Virilization, so do they look like they have normal male distribution of hair, and do they have normal male distribution of muscle? And one really good sort of differentiating question that I like to use in terms of virilization is I ask the man, if you needed to keep a clean shaven face, how often would you need to shave your face? Now, if they say every single day, they've probably got fairly normal testosterone levels and normal virilization. If they said, maybe once every week or two, then that may be suggestive that their testosterone levels are low and they've got low virilization. The testicular exam is really important, particularly in the azoospermic men. The picture that I've got there is orchidometer. So these are basically mimicking the size or the volume of different size testes. So what you do is you palpate the testy and you have the orchidometer, and you basically are comparing and measuring and trying to figure out exactly how many mils that testy is. So the size and volume is extremely important. The smaller the testy, the less likely that you are going to find sperm from that testy. The bigger the testy, then often that's a good sign. And the consistency is also really important as well. So if they are very, very firm, that's not necessarily a good prognostic sign. But alternatively, if they are very soft, then that's also not a great sign either. So a normal consistency is really important. The presence of the vas deferens, because obviously that's going to potentially lead you towards a diagnosis as well. And I'm always also thinking about sort of access in case I need to try and get sperm from the testicle in an individual man. I will go through that process a little bit later on in terms of, getting sperm from the testes. So I'll come back to that in a little bit. So what are some simple things that guys can do to improve their fertility? Weight loss, if they have a raised BMI, is going to improve factors from a few different perspectives. Number one, there is an effect on just a high BMI on spermatogenesis because of hormonal changes within the man, but there is also just an actual physical effect on it, that if the man is extremely overweight, then the testes are going to be hotter because generally there's more body tissue surrounding the testes, and then that affects the spermatogenesis as well. So weight loss can be very helpful. Obviously, quitting things that are not good for sperm, such as smoking, vaping, reducing or quitting alcohol, and then if possible, ceasing or reducing other medications that can affect sperm production. So if they are prescribed by another specialty, then perhaps going back to that specialty and seeing if there's any alternatives for medical treatment there. And obviously, if the man is indulging in some gym derived steroids and testosterone, then he needs to completely stop those. Interestingly, for sperm health, regular ejaculation is very, very important. Some couples come to me and they are aware of the female most fertile time frame, and they think that if they basically don't have sex for the rest of the month and just then aim for those few days in the middle of the cycle, that's going to be the best thing. It's actually not. It is much better for the health of the sperm to be regularly released, and I've got a slide next about why, but I would usually advise all of my male patients to ejaculate at least 2 to 3 times a week regularly to just keep the health of the sperm. So why is it important? A shortened sperm transit time improves the health of the sperm. So that's likely because the longer that the sperm sit waiting to be ejaculated, there is an increase in reactive oxygen species as the sperm pass through the epididymis. So if you can shorten the time that the sperm spend in the epididymis, then that's potentially protective and will reduce the chances of that sperm being damaged and increase its function. So the one thing that you can do is, if you see poor sperm parameters, then you can get the guy to do serial daily ejaculation for 4 days, which can actually reduce by 25% how much effect you're getting from sort of reactive oxygen species and abnormal semen analysis parameters. So a lot of guys are not aware of that, and it's a really simple thing that you can do if you're seeing a couple who are starting out and they're wanting some hints and tips about how to improve their fertility. Definitely regular ejaculation for the guy. What can you do that's really, really simple? Some simple treatment options for men are antioxidants, and there is reasonably robust evidence for most, if not all, of these. So mild derangements in, say, for example, motility and morphology, I would often recommend a combination of something like Menavit or similar. There are many different sort of men's fertility vitamin supplements out there on the market, and plus or minus coenzyme Q10, or otherwise known as ubiquinol. For more severe derangements, much higher doses of antioxidants are recommended, and the cocktail that I would use in that setting would be high-dose vitamin C, 1,000 milligrams a day, high-dose vitamin E, 1,000 milligrams a day, and definitely adding coenzyme Q10 or ubiquinol, 300 milligrams a day. So there was a systematic review of coenzyme Q10 that was done in 2021 by a group led by Salvio, and it included a substantial amount of studies on the use of coenzyme Q10 to improve semen analysis parameters, and all studies showed a benefit. The issue was that there wasn't complete consensus about the dose, but the most studied dose seems to be about 300 milligrams a day. So that's what I recommend to my patients. It's quick, it's simple, it's over the counter. You don't need a script for any of these things, and they can lead to, if there's nothing else underlying, substantial improvement, particularly in the motility and morphology. So I would regularly recommend these. The one thing that I do find is that not everyone is sort of aware of this. I had my secretary contact me the other day because I told a man to go to a pharmacy and get Menavit and CoQ10 and start taking it regularly. And he rang back saying, well, I did that, and the pharmacist told me that I absolutely should not be using coenzyme Q10 for fertility, that it was only for heart health, and that's the only reason why you should be using it. And you definitely couldn't take the combination of Menavit and CoQ10 together. He was essentially told that it was going to be dangerous. So I think just reiterating to men that there is definite evidence of an effect of these medications on sperm health and potentially on their fertility, and that if you're sort of getting pushed back by anyone else around, just to say, this is definitely what I want you to do. In terms of the evidence for Menavit, there probably is an improvement on some things, but the evidence is not quite as robust. And the one sort of thing that was put out was that in the discussion was that there wasn't any actual DNA fragmentation results on the men in a randomized control trial. So was it actually having an effect on the actual DNA damage within the sperm, or was it just the parameters such as motility and morphology? But I must say, in clinical practice, I do see an improvement in sperm parameters from these things. Vitamin C and vitamin E do have reasonably robust evidence behind them, using a gram of each a day. And there are definite studies that have been done, and in fact this one often comes up in O&G exams. So just a little bit more about the sperm DNA damage assays. So there's several different ones that you can sort of order. They're just using slightly different tests, and they're looking for the percentage of damage of the DNA within the sperm. Now, obviously, sperm, their whole and sole function is a DNA delivery device. All they are trying to do is to get the male proportion of the DNA that's going to make up half of this new human that's being formed to the egg. Once the DNA from the sperm is delivered into the egg, the sperm have kind of done their job. So if the DNA that's within that sperm is damaged, then that sperm and its function and its effect on the developing embryo is going to be substantial. So if you find that there are substantially high levels of sperm DNA damage within the sperm, then you need to do something to try and improve that, and using these high dose antioxidants, and definitely the high dose ones in the setting of significant DNA damage is really important. It also can just sometimes lead you to understanding a little bit more about why that couple, even if you're doing, say, IVF and you're getting poor embryology, why that might be happening. So is there substantially high levels of DNA damage, and how much impact is that having on the early embryo development? So this is just a little bit more about why it's important. So basically, sperm don't have the ability to repair themselves. So they're a simple thing that is really just trying to get to the egg and deliver their DNA. They don't have the capacity within themselves to repair that damage that's been done. So any oxidative stress that is being applied to the sperm, say for example with longer transit times within the epididymis, or from very, very poor lifestyle factors such as smoking or substantially high alcohol use, then that's going to lead to higher and higher and higher levels of DNA damage. The sperm can't fix that, and therefore the DNA that's being delivered to the egg is poor. It just even obesity and inflammation, are there as other factors that can lead to high reactive oxygen species. So what happens within the sperm is that there's a loss of the tight packing of the DNA within the sperm, and the egg can repair its own damage to an extent, and it can also repair very low levels of DNA damage from the sperm. But if the entire DNA or a substantial portion of the DNA that's been delivered by the sperm is abnormal, the egg just doesn't have the capacity to fix that completely. So it can lead to damaged genes that are being passed on to your offspring, or increase the risk of that embryo not implanting and growing, or increase the risk of miscarriage. So it is important. So what can you do to treat it? So we've just talked about a number of things. So lowering reactive oxygen species by having a short transit time. You can give them antioxidants to try and help with that. Or you can potentially even collect or obtain the sperm before the damage happens, so before it leaves the testes and goes into the epididymis. So once you collect sperm, either from a semen analysis sample or from testicular sperm, you can do several things to try and pick the best sperm, or the ones that are less likely to have higher DNA damage. So we wash the sperm to try and get rid of the ones that are potentially damaged. There are a number of different what we call sperm sorters. These are extra things that the lab can use that they basically put the sperm through, and the ones that reach the other end are the ones that are less likely to be damaged. So picking those sperm over the ones that didn't make it through these sorters. Pixie and high magnification ICSI, so they're just some extra different things that can be done in the lab if there are substantial issues with high levels of sperm DNA damage. So what are some other treatment options for male factor? So there are definitely surgical treatment options. So one thing is a preventative thing, and this is basically for childhood, and that's correcting cryptorchidism. So if cryptorchidism is found in a young boy, that needs to be corrected in a timely manner so that it will have a potentially less impact on spermatogenesis once it begins in adolescence. So if you look at severe oligospermia or azoospermia, if you've got untreated unilateral cryptorchidism, you're going to get 50 to 70% of men with poor semen analysis. But if you fix that pre-pubertally, you drop that down to 37%. And if it's bilateral untreated, it's 100% will have an abnormal semen analysis. But again, if you treat it pre-pubertally, you drop that down to 70%. So you can help to prevent male factor infertility in these men if it's done in a timely fashion. Varicocele is controversial. If you look up textbooks, in previous publications, and particularly even when I was going through training, you read a textbook and it says fix a varicocele and you'll improve semen analysis parameters. That is now thought to not necessarily be the case. Varicoceles are present in about 15 to 35% of normal, healthy, fertile men. The chances of finding a varicocele does go up in a population of men who have an abnormal semen analysis. So it probably goes up to about 25 to 44%. And these days, we only are really recommending it for very symptomatic large varicoceles. And there are a reasonable proportion of urologists around the traps who won't actually fix varicoceles at all until after the man has completed their fertility. So there's been a definite change to only considering varicocele repair in very sort of limited circumstances. Now, vasectomy reversal is one of the biggest surgical things that is done on a very routine basis around the country to restore fertility. So vasectomy is a really common method for contraception, but there are a lot of men who are now having second or subsequent relationships after they've had a vasectomy. I will always talk to couples where a vasectomy is in place about the pros and cons of repair versus using IVF with testicular-derived sperm. And the factors that go into it are how long ago was the vasectomy, because the length of time from the original vasectomy to the reversal has a substantial impact on the chances of success. How many children do they want? Are they wanting, 5 or 6 children versus, we really only want one more child? And other factors that are specific to the couple are really important as well. So if you've got a female who's 28, 30 and seems like she has no other fertility factors that you can see that's concerning, and the man had the vasectomy 3 years ago, a reversal actually might make more sense for this couple, particularly if they're wanting multiple children, because it gives them multiple chances to conceive spontaneously. If for example, I see a couple where the vasectomy was, say, 15 years ago, she's 40 already, and they only want one child, vasectomy reversal really might not be the right move for them, because the time frame to actually get the surgery, have recovery time, have restoration of sperm in the ejaculate, and then have time to try for pregnancy and see if they are successful on their own, you just might not have that time on your hands if the woman's age is a factor. So I will always give a general discussion about the pros and cons, and then if they want a reversal, then I would refer to one of my colleagues in Sydney, such as Derek Locke, for consideration of a reversal, and he would obviously go through the pros and cons of either as well. There is still, even if a reversal is successful and there is sperm in the ejaculate, there's still a reasonable percentage of patients who will end up not falling pregnant after a year of trying and will need to go on and use IVF anyway. So they always need to be warned that a reversal doesn't always equal success, and some of these couples who choose that pathway may end up back in my office needing IVF down the track. There are some rarer things like ejaculatory duct cysts that fixing those will actually improve sperm production and allow sperm, improve sperm transit and allow sperm to be released. And obviously then we'd be using our urology colleagues for something like that. So what are some actual sort of fertility type treatment options that are not just simple things? So the two major things that we do is IUI, or intrauterine insemination. A lot of couples say to me, well, if the sperm are poor, we'll just do IUI. But there needs to be some particular parameters that are met for it to be helpful, because you're still only just moving the sperm up into the uterus rather than the sperm being deposited at the top of the vagina. So there still needs to be certain semen analysis parameters that are met. There is an extra test that the scientists can run called a trial wash to be able to see whether the sperm is suitable for IUI, and I'll talk about that a little more on the next slide. ICSI, though, is going to be one of the major keys for most male factor infertility. This is why it was invented in the first place, and it's been absolutely overnight it changed how we treat male factor infertility. And then testicular sperm retrieval, and there's a number of factors that can go into what's done, who does it, and how we use that sperm. So IUI, basically what are we doing? In IUI, we are tracking the woman's fertile time. So we're usually doing that with blood tests. So we're doing blood tests to look for the LH surge in the woman where we know that that coincides with her most fertile time. We are then getting a semen sample. We are washing that sample up to get the best of the sperm, and then we're injecting the sperm directly into the uterus. So we're bypassing the vagina and the cervix and going right up to the uterus to try and improve the chances of success. The issue is that you still need a certain amount of sperm for it to have any chance of being successful. So over 5 million motile sperm at least to make this a reasonable alternative for couples. I do, however, mention it because there are definitely some patients who, for religious or ethical or other considerations, are never going to consider doing conventional IVF with ICSI or those kind of interventions. One couple stands out in my mind. This couple had a spontaneous pregnancy as their first attempt to conceive. And then had come back to me with secondary infertility, and there was a reasonable abnormality on multiple repeat semen analysis. So he had a low concentration, he had poor motility despite regular antioxidant use and regular ejaculation. And really the parameters in my mind were that they were only going to be potentially suitable for ICSI. Having said that, this couple had a major religious objection to IVF with ICSI or IVF in any form and would just not contemplate that no matter what. They went away for a little while and they came back a few years later and they just said, look, we understand that the chances of success with IUI are going to be substantially lower, but over that time frame he had a large varicocele repaired and his semen analysis parameters, although not normal, were slightly improved. And we did a trial wash in our lab, and my head scientist thought that it was worth a try, and they got pregnant on the first attempt at IUI. So although it's not used overly commonly in male factor fertility, there are circumstances where we will contemplate it. So ICSI, this is our absolute biggest winner for when we are talking about treatment of male factor infertility. Essentially, the couple needs to go through a normal cycle of IVF, so we still need to get the eggs. So the woman will go through a cycle of IVF as per normal. We will then collect the eggs, and then we will have the sperm sample that day. Now, that might be either from a semen sample that's from an ejaculatory sample, if there are some sperm in the ejaculate, or it may be from testicularly derived sperm, if that's it, where we're needing to get it from, say, for example, in azoospermia, or in some circumstances, it may be from frozen sperm, say, for example, if a man had cancer and he banked sperm prior to his cancer treatment and now he has complete testicular failure and doesn't produce sperm anymore. So wherever the sperm are coming from, if there are not normal semen analysis parameters, we would use the process of ICSI. Essentially, when the eggs are collected, they are surrounded by a fluffy cloud of other cells. Those cells in the normal situation would help attract the sperm to the egg for fertilization. But when we need to look at the eggs and inject them, all those cells are stripped off. So those cells are stripped off by the scientists after the eggs are collected, and then the scientists can actually look at the eggs and see which ones of them are actually mature eggs. In the picture up on the screen, in figure 1A, so essentially the thing on the side is basically a small, very low powered vacuum, essentially, to keep the egg steady. The egg is then orientated so that the polar bodies are either up the top or down the bottom, so at either 12 o'clock or 6 o'clock. And that's so that when the needle goes into the egg, it's not damaging the spindles within the egg and therefore not damaging the DNA that lies within the egg. Then the scientist would choose one, hopefully if the man has good motile sperm, but one normal shaped motile sperm per mature egg. If the sperm are moving around a lot, they often just whack the sperm on the tail to stop it moving, so that then they can suck it up easily into the needle, and then they'll inject one sperm directly into each egg. They have a special microscope with lots of handheld devices on the side for manipulating all of the different things that they are using for this. It is quite cool to watch. So when we are getting the sperm from the testicles, which patients are we going to be doing this from? Patients with azoospermia, either of an obstructive type or of a testicular failure type, men who have a vasectomy in place that has not been reversed, or men where there are substantially higher levels of DNA damage or very, very few sperm, and we are trying to get the sperm before the DNA damage potentially happens. Retrograde ejaculation, although there is a possibility that we can use sperm from the urine, we just need to correct the pH of the urine to collect that. But if we're still getting poor sperm samples from the urine, then we can go directly to the testy. And sometimes we would contemplate doing this if there are extremely poor IVF outcomes due to male factor infertility, and we think that that's because the sperm's passage through the epididymis and ejaculatory ducts, and we are trying to get the sperm before it gets to that point. So there are a number of different ways that we can obtain sperm directly from the testy or the epididymis. So you might hear terms like PISA, which is collecting sperm directly from the epididymis. An example of who you might do that in is someone who's had a vasectomy reversal, has a vasectomy in place. So in those men, there should be sperm in the epididymis because there shouldn't be any issues with them making sperm, they just can't get out. A teaser is where we're getting sperm directly from the testicular tubules, or we can do an open biopsy where we actually open the testy up and get sperm directly from the tubules, but we might be getting just a bigger sample. And then there is something called a microsurgical teaser, and that's where there's a use of an operating microscope to actually identify which tubules have the sperm within them and not damage other testicular tissue. I'll go through the microsurgical teaser with some pictures soon, but there are only certain practitioners who will do this. So the practitioner that I refer to for this is Derek Locke. There are a few people around the traps, but no one in Newcastle is doing microsurgical teasers, so we do send our patients to Sydney for this. The issue with the microsurgical teaser is that because there are hardly any sperm that end up being found, so this is in really significant cases of azoospermia, the sperm need to be used straight away. There's not really enough sperm to freeze it. And so there needs to be a consequent IVF cycle so that the eggs are collected on the day that the microteaser is performed, so that then if sperm are found, they can be injected directly into the eggs on the day. If no sperm are found on the day, because that is a definite potential, then the eggs are frozen for potential use with donor sperm. So in terms of what procedures I would regularly do PISAs and teasers for my own patients, and I would not infrequently also refer on to Derek to do a microsurgical teaser. way I would differentiate who I would be happy to do and who I would send on. So anyone who has a vasectomy in place with proven previous fertility, I'm very happy to do. They should have sperm there. It should be easy for me to find, and those ones I have no problem with. The azoospermic men, where it's something like cystic fibrosis and therefore it's an obstructive issue, again, they should be making normal amounts of sperm. It just can't get out. So mostly those guys, when you examine them, their testes feel quite normal. And I, again, be very happy to do a procedure to get sperm from those guys. In the azoospermic men, where we don't have a diagnosis at that stage as to why they're azoospermic, it is somewhat up to the combination of their hormonal parameters and their examination that would make me want to refer on or not. So if they've got reasonably normal hormone profiles, so the testosterone is low normal, and the FSH and LH are not particularly raised, and when I examine them their testes aren't very, very small, then I think I've got a reasonable chance of me finding sperm with an unguided biopsy essentially, and I would keep those guys in Newcastle. The guys that I would refer on much more quickly is when they've got much more abnormal hormone profiles, particularly really raised FSH. The chances of me finding sperm in those guys is much lower. Those guys, if they're making sperm, it's often very, very, very few sperm in very small pockets within the testes, and the chances of me finding that with an unguided biopsy is really low. The other parameter that would make me want to refer on is very small volume testes. When I'm doing an unguided, even with just a very small needle, I'm still damaging testicular tissue while I'm doing that. I therefore, if the man already has very small volume testes, am going to potentially compromise that testicular function later on down the track. I just referred recently a couple down to Derek for an opinion because the man's testicular volumes were 8 and 10 mils on either side. That's extremely small for a grown adult male, and I was very, very worried that A, I wasn't going to find sperm, and B, I might compromise that man's testicular function by me doing an unguided biopsy. So from my perspective, I think he'd be better off going to Sydney and having a microsurgical teaser. So this is just a sort of a schematic as to where we might be getting sperm from. So the teaser is directly from the testes. So what we do for these guys is we put a cannula in. I give them some sedation, so some fentanyl and midazolam, and then we put a block in around the spermatic cord. So we essentially sort of lift up the spermatic cord and put local anaesthetic all around that, and then they get a small amount of local anaesthetic over their scrotal skin. I've got a butterfly needle. It goes into the testes and it's attached to a 20 ml syringe. And then my nurse has the worst job of the whole procedure, which is pulling that syringe right back up to the hilt and essentially creating a vacuum. So what we're trying to do is move around the testes and stick the needle in and out of the testes without coming completely out, so we don't lose that vacuum effect, and just trying to get tubules sucked up into the needle and the for us to then use. A Pisa is very similar, except you're sticking the needle into the epididymis rather than into the testes. And then the top right hand one is trying to sort of show you an open biopsy. So that's where we're actually making a small, about 1.5 centimeter incision, and then getting to the tubules and then cutting off a portion of the tubules. And then a MESA, which I don't really do. In terms of the microsurgical teaser, it is much more complicated. It's done in an operating theatre. It can take even up to a couple of hours to achieve, and the man is under a general anaesthetic because it's a much longer, much more uncomfortable procedure for them. The testes is essentially split open, and then using a operative microscope, the tubules will be looked through to try and identify tubules that may have sperm inside them, and then a sample is taken of that. And then there's a scientist in the room with, well, they're often taken into a separate lab, and those sperm the tubules are opened up, the sperm are found, and then they can be used to inject directly into the eggs that day. Just going back to the previous one, when I do a teaser or a PISA, one of my scientists takes that sample directly into the lab, and they'll use one of the microscopes in there to see whether they can find sperm. We will start with just one side, and then if I get particularly, for example, say in a vasectomy patient, one side might be all that's needed. They may say there are absolutely oodles of sperm in that sample from that one side. You can stop what you're doing, that's enough. But oftentimes, if we're looking at sort of lower sperm numbers, then I'll go ahead and get a sample from the other side while the scientist is looking through the first side, so that they have more sperm to potentially find. Generally, the teaser and the PISA are done either on the day of the egg collection if you are sure that there is sperm there, or if you've already previously proven that there's sperm there. But we also do a diagnostic. This is separate from an IVF cycle, just to see whether we can find sperm. And that sperm, if there is enough of it, can be frozen. So some guys never need more than one procedure. And by the time that they come back and the woman has her IVF cycle, there's enough sperm there. I've got one couple that come from Port Macquarie. He was found to be azoospermic. His parameters were all quite okay, so his hormone profile was reasonably normal. His karyotype was normal. His examination was quite normal, so he had normal sized testes of a normal consistency. So I was fairly sure that I would find sperm in him. And indeed I did, and we found enough that he actually had multiple straws frozen from that first diagnostic procedure, and they've subsequently come back and used a small portion of that sperm for an IVF cycle, and they have an ongoing pregnancy at the moment. And he, as far as we know at this stage, depending on how many children this couple want, hopefully won't ever need to have more than one procedure. Sometimes there is such few sperm made that yes, we can find sperm when we do this, but we have to repeat it each time they do a cycle. So the egg collection is done, and then the man's there, and then he has his procedure straight after. So that is most of my talk tonight. I haven't actually seen any questions pop up yet, but I'm very happy to answer anything in relation to anything that I've already spoken about, or any other general questions that anyone has about male factor fertility. So I'll leave that to the listeners now.
If anybody is, oh, there's one. Excellent. Alison just said, great talk. If anybody is having trouble locating the oh, there we go. Laura's put it through, but I was going to say if there are any issues in the question box, please put them in the chat box as well.
Yeah, so there's a question there that says, should every male trying to conceive take coenzyme Q10? Look, I think probably not, but any man who has any kind of abnormality, particularly with the motility or the morphology, the antioxidants don't tend to help the concentration of sperm. So how many sperm a man's making, they're really only affecting the quality or the movement and the morphology. So I generally will recommend it to those guys. Having said that, if I've got a couple who have had poor IVF outcomes, and even with completely normal semen analysis parameters, I will just get them to start taking it, just so that we've kind of accounted for that as well. There's a question there from Hannah, and I think I'm not seeing all of it. how do I see all of it? Oh, there we go. So yes, having a low percentage is common. So the question is, I mentioned having a low percentage of normal morphology is common. Does that count as a point in the number of factors when assessing chance of fertility? It only counts if it's actually below the normal range. So if there is, say, morphology of 5%, which I know some guys get really worried about because it's so close to that lower end of the normal range, that wouldn't count as one of those factors. But if the morphology was, say, 2% or 3%, and so is definitely under the normal range, then yes, it would. No worries. I just got a thanks. Any other questions at all? So I think just basically take-home points for tonight. Male factor is reasonably easy. Do a semen analysis. If it's abnormal, repeat it. If you're just giving some general advice to couples, then regular ejaculation is a really good one and a good simple one, as well as just lifestyle factors, which I know all of us talk to patients about on a day-to-day basis. And mostly, except for the very small percentage of men who are azoospermic and have no sperm found, mostly male factor is very, very treatable. That would be my biggest take-home points.
Excellent. If there are no other questions this evening, no. No worries. Thank you for joining us tonight, everybody. And thank you so much to Dr. Fuller for being with us this evening. Please don't forget to fill out the evaluation survey, which I'll either pop up on the screen at the close of the webinar, or it will also be sent to your email. If there is any resources that have come up from tonight, they will be forwarded on tomorrow as well. Thank you, everybody, for coming, and we look forward to seeing you at webinars in the future.
And thanks so much for having me.
No worries. Thanks, everyone.